Welcome back to Daybreak on Trust TV. We've just spent time hearing from you, our viewers, about your experiences at primary healthcare centers, your challenges, frustrations, and the small victories when services work as they should. Now, the stories remind us that behind every policy and fund, there are real people whose health and lives depend on functional primary health care. Now we turn to a deeper discussion on primary health care, analyzing interventions and their impact on the quality of service delivery. We'll explore how government programs, funding mechanisms, and community involvement are shaping the way care is delivered across the country. Are these interventions reaching the people who need them the most? And how effective are they in improving outcomes on the ground? Now, joining us to shed light on these questions via Zoom from Enugu is Dr. Simeon Onyemaechi, Managing Director of the Anambra State Health Insurance Agency. Dr. Onyemaechi is a public health physician with a PhD in public health, specializing in health financing and health systems development. He will provide insight into policy, funding, and the overall structure of primary health care delivery. And joining us, he's almost here, joining us in the studio. We'll also be having Dr. Great Otosin, CEO of Daily Lifesavers, an NGO delivering community healthcare services across rural Nigeria and difficult areas in Cameroon. So let's jump right in, since Dr. Simeon Onyemaechi is on the line waiting for us. Good morning. Thank you for joining us this morning.
Thank you. Good morning. Good morning, viewers. Happy to be here from Oka, not currently in Enugu. Thank you.
Good morning. The first question I would love to ask you this morning is concerning the funds that has been released, which is a 32.9 billion naira. I would want to know what mechanisms are in place, that is at local government areas, states levels, to ensure that this particular fund that is being disbursed is actually going to reach the primary healthcare facilities and used for the intended purpose.
Yeah, thank you so much. If we go back in time, the crafters of the National Health Act 2014 were very intentional in Section 11 that created the Basic Healthcare Provision Fund. That section stipulates that there shall be for Nigeria a Basic Healthcare Provision Fund which shall be funded at least with 1% consolidated revenue of the federal government, and then donor support, philanthropy, state counterpart funds, and what have you. And all of that was to serve, or is to serve, as a basket funding that will change the narrative of how things were done. In the past, there were lots of bureaucracies that first there was a failure, quite frankly, of governance of primary healthcare level, because primary healthcare is ideally and constitutionally the responsibility of the local government. But then, like we all know, there was really a near non-existent local government system in Nigeria. And even where they existed, they were not as functional as they were up until about 1993. So for that reason, there was a need to look again at the entire landscape of primary healthcare delivery system in the country. Then that 2014 National Health Act, which in my considered opinion is a watershed piece of legislation, put together and crafted it in such a way that there will be created for the first time mechanisms to ensure that the funds that are released for primary health care are really managed with accountability, transparency, equity, and those kind of key elements in place. Now, the fundamental shift in strategy is that funding will go directly to facilities, direct facility financing, which will, for the purposes of accountability and visibility in the entire pipeline, should go first from the Federal Ministry of Health where these funds will be released on quarterly basis, like you just talked about, the 32.9 billion naira for Q3 implementation of Basic Healthcare Provision Fund, which was announced by the Honorable Coordinating Minister for Health and Social Welfare following the Ministerial Oversight Committee on Wednesday last week. Now, that money will go through 4 different gateways. There is the National Primary Health Development Agency gateway that gets about 45% of that fund. Then the National Health Insurance gateway that gets about 48.25% of that funding. And then 5% will go through the National Emergency Medical Treatment gateway of the country to take care of matters around ambulances, treatment of emergency conditions for all Nigerians in states that have commenced implementation, about 25 states or so in the last count, within the first 48 hours when people have emergency need, and then they call in 112, which is the National Emergency Hotline. Then the final component, 1.75%, is to go to the National Centers for Disease Prevention and Control, NCDC gateway, to take care of emergency conditions. Just like when we had COVID, if we had this kind of funding, there would have been some form of ready funds to deploy for that kind of intervention. Now, when these monies go through these various gateways, the money going through primary health development gateway, which is the 45%, will come from the federal government, trickle down to the state primary healthcare development agencies, CBN treasury account, just for visibility, for them to just see the pipeline and monitor how that money is utilized at the lower levels. Then immediately that money gets to the state's primary health emergency accounts in the various states, 36 states of the Federation and FCT. That money is disbursed directly from that CBN account to commercial bank accounts of every participating primary health center in the country. As of today, we have almost 9,000 primary health care centers, but with this new funding, that number has increased to about 14,000, because the Honorable Coordinating Minister for Health was very clear from day one that we needed to expand access to care. The ideal thing is that wherever you reside within 5 kilometers radius, you should have access to primary health care services. So to take it up from the about 8,800 thereabout PHCs to currently about 14,000, with the ultimate goal of getting to about 17,000, because he intended to double the numbers of PHCs implementing basic healthcare provision fund. So where we are today is that once those monies hit the commercial bank accounts of all of these participating primary health centers, the money is to be used for 3 different things: to ensure that there's optimization of human resource for health, to fix basic infrastructure, such that we must have running water. For water, sanitation, and hygiene, there's no primary health center that has any business not having running water to actually run their operations. To fix issues around solar, to ensure that there is power in all of those facilities, to ensure that when there are leaky roofs, bad floor, broken fences, and what have you, a component of that money is used to fix it. And the last component is to be used to procure essential medicines and to optimize vaccine. Now, the money, and this is to prepare these primary health centers to serve very well their function of supply side service delivery, to get the facilities ready in a way that it becomes attractive for people dwelling in all of these wards, political wards in Nigeria, to be able to walk into the facilities, and then those facilities will be good, have what it takes to offer the services containing the basic minimum package of health services that Basic Healthcare Provision Fund money is supposed to procure. Now, the 48.25% that goes to the National Primary Health Development Gateway is then to be disbursed to all the state's social health insurance agencies in Nigeria. Every state government have a functional state health insurance agency. Now, these monies will be disbursed to each of the state's health insurance schemes to then register Nigerians from every political ward using equality. Now, I use Anambra, for instance. When that money comes here, currently every political ward in Anambra have 140 Nigerians residing in each of the 326 political wards in Anambra State who have been enrolled in the Basic Healthcare Provision Fund and issued Basic Healthcare Provision Fund identity cards with national identification number to verify who these individuals are. And they have been assigned to go to each of these primary health centers in the various wards to access this care. And every month, monies are paid as capitation for them to the so that they can then seek this care. That's how this 32.9 billion is to be administered ultimately for people to have health.
Dr. Onyemaechi, all right, let's get to our guest in the studio, Dr. Great Otosin. Thank you for joining us.
Thank you for joining us. Good morning.
It's my pleasure. Thank you so much.
All right, we'd like to hear from you from your on-ground experience. What are the main challenges rural and underserved communities face in accessing primary healthcare services?
All right, basically, health care services is so important today, but a whole lot of people don't know what to do when they are sick. Now, basically, I've met a lot of people and they are telling us they don't have money for health care. They don't have money to do this or do that. And we are here today to let Nigerians know that majority of what we are going through in our health is caused by today's drinking water. We call it water crisis. Water crisis is the largest contributor to today's health crisis. Now, how do we remedy this? In the days of our grandparents, they were drinking water from natural source. And they
but we're trying to focus on how accessible these healthcare facilities are to, underserved and rural communities, in the sense that at this point the federal government has disbursed a lot of money in making sure that these facilities are up to par, but it has become quite hard for people in underserved and rural communities to access because the facilities are not up to par, equipment as well as manpower. Yeah. So what are the major challenges when accessing those, and how can those challenges be tackled?
Well, we need to create more awareness. We need to meet with the clan heads, village heads. We need to educate these people in their own local languages to let them understand the need for these things. And then we need to also let the government know what is really lacking in these healthcare facilities. There are so many primary healthcare facilities, and the thing is just there. The grasses have grown, and we need to do more. We need to do more in a way that lets people get to know that there are things like this, and it can help them in many ways. There are many places that we have seen, we have come across, they don't have even the least medicine is not available there. And a lot of people say that they have gone there and then they don't have that medical care, so they prefer going out to other big facilities in order to get this. So governments need to do a whole lot to make these facilities have the basic things they need in order to help people, get access to it.
All right, now with this disbursement, how can they hold the people responsible accountable for the funds that have been disbursed to, various communities, and the people responsible in making sure that these implementation are put on ground?
We need to raise a team that will go around these facilities to ensure that these monies, these funds are disbursed to the right source. People are complaining that, okay, money have been disbursed, but they are not seeing it. It's not reflecting. Maybe there's somebody somewhere that is just siphoning it. And we need to bridge this gap so that these things can get to the people that we really make this thing available for. So we need to bridge that gap.
All right, Dr. Onyemaechi, can you hear me now?
Yes, I can hear you.
Dr. Onyemaechi, are you there?
Do we still have Dr. Onyemaechi on the line?
Yes, I'm here. I can hear you.
All right then. According to the red letter that was dated on the 22nd of October 2025 and officially released on the website of the Federal Ministry of Health and Social Welfare, where we got this announcement about the disbursement of the 32.9 billion naira fund for the primary healthcare system. We want to know how much of an awareness has this been created? Because the minister said it is up to the people in the community to track if these funds are being utilized and used for the right cause. So I would love to find out from you how much awareness have been created, because one of the major issues we see when all of these funds are being released is accountability and transparency. So at the end of the day, we want a situation whereby these funds are being managed judiciously and used for the right cause. So we want to know from you this morning how much awareness have been created, and how can the people in these communities be able to hold the right people accountable if these funds are not being used correctly at the end of the day?
Yeah, first is to assure Nigerians that these funds are being utilized at the primary health centers. It is not all the primary health centers in Nigeria that benefit from basic healthcare provision fund. There are designated PHCs, one PHC per ward, where these monies go to directly to procure services for Nigerians that have been registered in those facilities. Before this minister came on board, we had about 1.9 million Nigerians registered on this platform. But today, about 3 million Nigerians are accessing basic healthcare provision fund services from across these primary health centers. And the accountability mechanism is woven in such a way that there is an officer in charge, call it the healthcare worker that is in charge of each of the various facilities, the head of the primary health center. That person cannot use those monies without a counter signature by a ward development committee chairman who is an indigene of that ward. These community structures exist, and I'm happy that we are having this kind of a platform to say it to Nigerians to go and verify. Every political ward in Nigeria, the traditional rulers, the community leaders have come together to elect a group of persons, maximum 15, who are in charge of issues around healthcare. And they are the ones who manage the primary health centers in the various communities in Nigeria. One of those persons acts as the chairman of that committee, and that person is co-signatory with the officer in charge of the primary health centers that are benefiting from basic healthcare provision fund. These monies have been going to primary health centers since the year 2019 till date. But just that with this minister, there has been an increment, at least doubling of the amount that go to these facilities. And there are Nigerians who are benefiting. I really want us to invest some time in investigative journalism to look at, I'm not saying there are no challenges. There are challenges because we have found some primary health centers where this community member, who is a ward development committee, has colluded with the officer in charge to siphon some of the resources, but they are in the minority. Majority of these primary health centers, data is there to validate this, that of the over 38,000 primary health centers in Nigeria, these about 14,000 primary health centers that are providing services through this direct facility financing and the health insurance model that the basic healthcare provision fund offer, they have higher traffic. The patient flow to these facilities are more. They have almost all of the services that are required. When this government came in at the federal level, the Honorable Coordinating Minister, through what he calls the Hope PHC project, have done some levels of clear work to solarize all of these PHCs in collaboration with the state governments. Most state governments have upgraded, because today we are having one conversation. In the past, states were having their own priorities separate from federal. But when this current minister came on board, Musalipate, he tried to to organize what is called the sector-wide approach, so that we can all plan together, have one plan, have one conversation, have one report, and then we can track healthcare progress together. Because when you say Nigeria's health indices are poor, for example, it will come from what is happening across the states. So he understood clearly that every state needed to make progress at the same time for Nigeria's negative indices to actually change. Therefore, today we have joint annual operational plans with the federal, the state, and the local governments. It didn't happen in the past. So that we are having one conversation. With that in mind, when we have done our data analysis, it is very clear. And I invite civil society organizations who, by the way, are members of the Ministerial Oversight Committee that oversee this fund at the national level. Civil society organizations are part of the oversight committee at the various state levels and even down to the local government health authority levels. But then the issue we are having is that of poor awareness. People who are assessing this care at the various communities, they know that these services exist, but the funding is not sufficient. And the minister himself is the first person to say it, that we have made lots of progress. Right. Imagine that today about 3 million.
Thank you for your review. Okay, Dr. Otosin, from your the on-ground experience, what are the main challenges rural and underserved communities face in accessing primary healthcare services? Okay, I think Hauwa has been able to, get that from you. But then let's find out how well equipped are the facilities to handle the funds and programs allocated to them, especially in remote areas, because we're more concerned with the remote areas, because they are the ones that are really, we are not saying that other areas don't need this the facilities, but the people in the rural areas were more concerned about them. So how do you think they can be able to access this?
Well, first off, we need to talk about, are these facilities there? Are they okay? At least 50% okay for people to get in there and then get these things.
Now, don't you think 50% is a bit low when it comes to healthcare delivery?
I have been to many healthcare facilities. There is almost nothing there, except this is there. Said both funds has been disbursed that these rural communities will have access to this. The facilities is not just the building. Are there things inside the building? Are there facilities inside the building that will make people that when they go there, if they can easily access the normal diagnosis, are these things there? So this is the first now. Okay, look at what we are seeing now. If you look at the screen now, you see that a lot of these things are not there, except it is there now. There is no transparency when it comes to this, and there are people. We just believe that governments have disbursed this money, that the people that are executing them, are they doing the right things? So this transparency is lacking. Most of these things, you just see them, it is there, but if you go there, it's not there.
You're someone who is on the field and then you get to visit these facilities.
Yeah.
Now we're talking about accountability and transparency, I beg your pardon, which you just rightly stated. So from your own point of view, being that you are in the system, how can the people in the community hold those responsible, just so in case if these funds are not being used for the right cause?
I think in every ward or community there should be a person that will be held accountable. Like if it is going to be the clan heads, it's going to be the what is it called now?
The local government chairman.
Local government chairman is far from the people, very far. Some of them are not even living in those communities. They are living in cities. They are only ruling from the cities. What we are talking about is the people that are on ground, people that are there. So if these things are not available, we run to them and say, okay, sir, this is not there. We cannot access this thing. So them now will not know who to hold accountable. But we can't, there's a counselor. From counselor, we get to the chairman. Even getting access to counselors. Some counselors are not living in those cities or in those communities. They are living in cities. So they are coming from cities, or most of them are not even once in a week, once in a month, twice in a month, they go to their offices. So we cannot hold these people except the royal fathers. It's easier for us to get to the royal fathers and complain to them. So I think we should use royal fathers to say, okay, sir, you are the person that can get access to these people that are ruling us, councillors and local government chairmen. So any complaint can be gotten from some people have their youth leader, right? Some youth leader, if they are good, if they are godly, they'll be able to stand in for the people. These things are not there. And then we use the youth leader to get to them.
All right.
So that would be fine.
Okay.
Thank you very much, Dr. Otosin. I don't know if Dr. Onyemaechi is still with us. I'd like to quickly ask him before we go. As an expert when it comes to health financing, what do you think the biggest gaps are in health financing and that still hinder quality service delivery in primary healthcare?
The biggest gap that we have is that of the manpower. When you go across most of the African countries, I always want to cite Rwanda. When people go to Rwanda, they just stop in Kigali. I have gone beyond Kigali to various provinces, towns, villages. And one thing is clear. They have the requisite human capital deployed in their primary health centers. Here in the country, we have depth of healthcare providers. So when you go to a primary health facility that is very well built with all of the equipment, and then there is no human resource for health to man that place, 24 hours, 7 days in a week, then we cannot have access to primary health care as it should be. So the accountability framework that needs to hold these human resource for health who have been deployed there to stay there and do their work needs to be firmed up. And that's not the responsibility of the federal government, it's the responsibility of all of us. I told you about World Development Committee chairman, the structure that has been thought through so that these people, members of the communities, we don't need to go as far to the traditional rulers. They have already done their job by delegating their authorities. These are structures that exist in the country. As far back as Professor Oliko Ransom Kuti, he was the one who designed this idea, a beautiful idea. Every traditional ruler have done that. You have members of these communities representing the communities who are supposed to be the eye of their own very community to the authorities to report when things are not going well. But sometimes we see them colluding with these persons who they are supposed to report to the authorities when they do not do their work. That's the challenge. And then we have the challenge as well of poor funding in terms of the requisite amount. Today, we only have total barely about 30% of what we need for the health sector. I am not an advocate of more money for healthcare system. I am an advocate of more health for the money that is sent to the health system. So the one that we have given so far, how well have we utilized it? And that is a collective responsibility for every one of us as citizens, because the highest office in the country is that of the citizen of the Federal Republic. That's why the Honorable Coordinating Minister issued that red alert. From all of our complaints, all of us always going for these meetings to say, look, we have done our part. Federal government, you've brought this money. The state governments have put their 25% counterpart funds. These funds have gone to the facilities as direct facility financing. We have enrolled Nigerians on care. The federal government recently have hired through the Hope PHC projects about 8,000 primary healthcare workers, community health extension workers, and what have you, and deploy them across the country to take care of the issue of human resource for health. The various state governments have equally done that in their numbers. In Anambra, we have recruited over 2,000 healthcare workers, very verifiable things. But then when you deploy these persons there, I am currently in Oka. Am I the one in Oka who will always stay in all of the 580 PHCs that we have? It's not possible. The structures that we have then put down to ensure that there is transmission of that feedback mechanisms, these systems, you claim to say, you want to say, let the owners, the beneficiaries in these various communities elect somebody to be the one to give us this feedback and to pretend over what happens in these PHCs. What else do you want to do? But I'm not sounding defeatist. We can do better. Some states have now begun to leverage on technology, to use technology so that people can clock in when they come to work and what have you. Let us have technology to look at the pipeline of medicine supply at these various PHCs, such that we can know when they are going on stockouts and what have you. If we can do some of this and then establish the ambulance system properly that can refer patients from primary health centers, because the primary health centers have their own basic functions: health promotion, health prevention, management of simple illnesses. That's what their work should be, and then they refer it is beyond them. So we need to get this to work for all of ourselves. Thank you.
Thank you for speaking to us this morning, Dr. Onyemaechi, a public health physician with a PhD in public health, specializing in health financing and health systems development. And also Dr. Otosin, thank you for speaking with us this morning. Thank you. And that is all we have for you for our discussion segment.